Today is supposed to be a talk about hemodynamics, how they are assessed non-invasively. So when we say the word hemodynamics, people think of pressure, people think of work, people think of flow. So we will try to give you an idea how you get to these quantities non-invasively. The definition of pressure is force per unit area. That's sort of the very basic definition. And these are the units, the SI units of pressure that are recognized. We usually do not measure force, but we have ease at measuring areas. And because we know force from Newton's second law is mass times acceleration, we can remove that quantity and put mass times acceleration divided by area. Again, I do not measure mass non-invasively, but I can measure volume. So I can get rid of mass and I go with density times volume. The whole idea is we go from one sort of fundamental equation and we try to replace variables in the equation with variables that we can measure. So it's density times volume times acceleration divided by area. Volume is centimeter cubed and area is centimeter squared. So you reduce this and you end up with a distance unit. So now we can say the pressure is the product of density of a fluid multiplied by the free fall acceleration. That's a constant, 9.8 meters per second squared for most places on the Earth, multiplied by the height above the center of gravity. Notice that the density of mercury is more than the density of water. And so if you have units of pressure measured in terms of, say, centimeters of water, and you want to convert them to mercury, you need less height of mercury to get to 1 centimeter of water. We usually do not go for absolute units of pressure, but we express pressure in terms of the height. Why? Because the free fall is a constant, and for blood, density doesn't change. So we can talk about pressure in terms of height of millimeters mercury, and that's what you will see frequently. Now we go to quantifying flow. Flow can be looked at as the amount of fluid that goes through this cylinder. And so the volume of a cylinder is area of the base multiplied by height. You say it's a cross-section of a circle. So that's the area of a circle. And we multiply it by velocity because that's the flow rate. If it's an ellipse, then I need to get the major axis, the minor axis, divide each by 2 and use that for the area equation. Some places in the heart it is more accurately represented by an ellipse than by a circle. For example, the mitral annulus. However, even if you do the circle approximation, you end up with rather close values to what you really measure invasively. I'll skip this for the sake of time, but when you think of flow in a given blood vessel, that's the wavefront that you are looking at, or the shape of the flow as you are looking at it, more or less of a parabola, with the highest velocity in the center, and velocities keep decreasing till you end up with a layer that is in contact with the wall of that vessel where there is no motion. What are the factors that oppose flow? For solid bodies, we think of friction. For liquids, we talk about viscosity. So the more viscid a fluid is, the more the frictional forces it will face. Blood behaves as a Newtonian fluid, and this is sort of a sentence that is better explained by the equation. But basically, if we look at the rate of the shear tension and relate it to the change in the velocity gradient, we are looking at a direct relation. This is the tension, this is the constant for that equation, and this is the rate of change of velocity. But it's a spatial change, it's not a temporal change. How the velocity changes over the cross-section of the tube that you are looking at. And the units of this are the Pascal second. Pascal is the units of pressure. We typically, again, do not measure viscosity when we talk about blood, but there are situations, for example, with hypercoagulable states where the viscosity of the blood is not the same as what a normal individual does. I'll go quickly through this slide and the next one, but it's basically trying to look at what are the determinants of flow and velocities that we measure. They are related to the pressure gradient across a tube. For motion to happen, there has to be a force. For flow to happen, there has to be a pressure gradient, higher pressure to lower pressure. And then the geometry of the tube determines additional data about the resistance the blood faces. So the length of the tube, the cross-section, we are assuming that it's a circle, and again, that's for simplicity and ease of calculations. You can look at different cross-sections. At equilibrium, the force that wants to push the blood from point 1 to point 2 is balanced by the frictional forces. And we just mentioned for blood, frictional forces is viscosity. This is a derivation of Poiseuille's law. I will spare you that part, but it's not really challenging if you go through it step by step. The long story here is that the maximum velocity is directly related to the pressure gradient and is inversely related to the length of the tube, is inversely related to the viscosity, but is directly related to the radius squared. If you think about it, and if for blood to go easily through a tube, the larger the tube, the less resistance it faces. The longer the tube, though, the more resistance it sees, and the more viscid the fluid is, the more resistance the blood sees, and therefore the velocity slows down. It's a reasonable approximation to start with, but it's not a perfect representation of what truly happens. We ended up with velocity on the last slide. This takes you from velocity, which is the mean velocity, to flow. For those of you who know some statistics, if you look at the mean value for numbers that are increasing in a sort of same increment, you can get to the mean value by getting the lowest and the highest, and you divide them by 2. So we are interested in the mean velocity, and that's what we see. Do you know what happened here? Okay, there it went back. Thank you. So this is the mean velocity, and we said it's just the maximum divided by 2. And then we go back to this equation, and we get flow, which is area multiplied by the mean velocity. And the area is pi a squared, where a is the radius. So this is the resistance, and this is the full Poiseuille's equation, where flow is directly related to the fourth power of the radius, inversely related to the length and the viscosity, but directly related to the pressure gradient. Pi and divided by 8 is a constant. Okay. So some quick comments about the assumptions related to Poiseuille's law. One assumption is that viscosity is constant. For the most part, this is true. But as you go into smaller and smaller blood vessels, red blood cells will not go in there. And so the composition of the blood changes. We typically do not image these blood vessels routinely by the conventional methods we have, and so it's reasonable to think of viscosity as constant. In normal flow situations, there is laminar flow. There is no turbulence except for a short distance in the pulmonary artery and the aorta. So again, assuming laminar flow is acceptable, we said the circular cross-section is the assumption we use to calculate the relation between flow and gradient and so on. And this is true except for tapering vessels. A more problematic assumption is that in all of the calculations, we assume that the area will not change with the flow. This does not happen. There is an elastic recoil. There is expansion, and then there is elastic recoil. So there is an error in assuming that we are dealing with inelastic tubes. And then the assumption that the flow is steady. As you all know, in the heart, flow is not steady. It's during one phase only. And then even within that phase, there is a varying velocity profile. Velocity at the beginning of ejection is not the same at the peak or at the end. Reynolds number is a number that tells you how likely this is the situation leading or giving itself or offering itself to turbulence. And basically, if you have a high Reynolds number, the higher the odds are for turbulence to occur. This is a derivation showing you that Reynolds number is directly related to the inertial forces. The inertia of any body is what allows that body to continue till something stops it. And then it's inversely related to the viscous forces. If you were to go through the math, and I will not take you through it, you will end up with units in the numerator that are the same as units in the denominator, so it's a dimensionless number. It has no units. We just talked about flow. Now let us talk about errors that we see by echocardiography in quantifying flow. So flow is area multiplied by velocity. If I make errors in the area, then I'll make errors in calculating flow. And of course, if I make errors in the velocity, I will also make errors in calculating flow. The most frequent problem, though, is the area error. The first one is the diameter measurement. The true diameter is, for example, 2.4, and I am measuring it 2. So that's a problem. A geometric assumption, we touched on that briefly. We say it's a circle when it's an ellipse. We talked about the issue of phasic flow and instantaneous area. The area in many places, and most noticeable, for example, across the mitral annulus, is not a constant throughout the duration of flow across the valve. It changes. And so if I measure it in one phase or in one point in time and assume that this is how the diameter is and therefore how the area is going to be for the duration of diastole, there would be error. Also, area is not fixed. Area changes. You are all familiar with this application in patients with aortic stenosis, pseudo-AS, where we increase their flows and see what happens to the valve area. Also, there has to be a proper site where we measure the diameter. We want to measure the diameter and the velocity at the same location. I cannot measure diameter at one spot and velocity at another spot. They have to be matched together because we are looking at flow at that particular level. And then there are some methods that would allow you, instead of dealing with diameter and then converting diameter to area, to say, let's just get the area measurement. And of course, if I measure the area wrong, if I planimeter it wrong, if the image is challenging, then that also can be error. So a famous question is being asked here, which is, if you have an error in diameter, what does that to translate in an error in area? And people frequently say it's squared because it's pi r squared. It is actually doubled, and this is the reason. It's sort of a pretty basic approach, and I will not dwell on that, but maybe we can, on one-on-one, go more over that for those who are interested. But basically, the error in the area is twice the error in the diameter. We talked about errors in area. How about errors in velocity? We assume that the velocity is uniform, and we just said, for the most part, yes, but not true all the time, particularly if we're looking at turbulent flows. We need to recognize which component of the spectral profile we measure, and the consensus is that we go for what is called the modal velocity. This is the velocity with which most red blood cells are moving and is recognized as the brightest part of the spectral envelope. If I can get a 3D spatial velocity vector, that would be the most representative. As you all know, flow can be represented along the x, along the y, along the z planes, and there is a net vector there that you can choose. If you were able to get that, that would give you the most accurate representation, but that's not what we're doing. The signal strength. The signal strength is something that we can control at times. Example, I get a signal from a patient and the signal is faint. If I display that signal and ask someone to measure it, it would not be as accurate. The converse is also problematic. If I crank up my gain, I can have a velocity increase maybe by 10 centimeters per second or even more. Another example for that situation, if you are imaging a patient on a mechanical ventilator, we have to record enough cardiac cycles, so we show recordings where the ventilator is not interfering with the Doppler signal. We talked about we need to measure area and velocity at the same level. However, we are not combining 2D and Doppler in the same image. We get 2D from one image and we get velocity from another image, and so they are not in the same cardiac cycle. Sinus rhythms, small RR variations, not a problem, but atrial fib, frequent ectopy, that can be a problem. And ideally, you want to do matching RR intervals. And then the assumption of continuity. What does that mean? It means that the flow that I measure, say, at the LVOT is the same as the flow that is, say, going to the mesenteric circulation. If you look at it, it's not true, because there are some flows or some blood that would have reached the upper extremities, would have reached the brain, and so on. How do we calculate cardiac output? It's something we do day to day. Ultrasound systems will do. It goes to the cross-sectional area multiplied by the velocity time integral to get stroke volume. Since most of these are triangles, you can get the area of the triangle as half base times height. Nowadays, we do not need to do these assumptions. Earlier time, this was how many of these calculations were obtained. And then if I want to go from stroke volume to cardiac output, I just multiply by heart rate. This approach has been used to look at the effect of drugs on patients in heart failure, has been utilized to look at the effect of different pacing modes, VVI versus AV sequential pacing. How do we adjust the AV delay? How do we look at the VV delay? Things like that. These are all very vivid applications of that principle. We can look at physiologic changes with pregnancy, labor, and delivery. We can look at what happened to fetuses and neonates. There was a time when children with hyperbilirubinemia were treated with phototherapy and things like that, and that produced vasodilatation and changes in cardiac output, and there was interest what happens to them. And also exercise Doppler, which is important because with exercise we want to look at what happens to pressure and also what happens to volume, so we can combine that and look at flows. Let's look at some quick applications. So how do I do flow through the LV outflow tract? Many of the fellows, the senior fellows, know this. It's the diameter multiplied by the time velocity integral, and here we are hugging the modal velocity. You can do the same for the RV outflow tract, TVI with the diameter. For the mitral annulus, this is recording at the annulus. This is recording at the tips. The filters are up here and they cut the baseline. This is not the level where we use flow acquisition. We want flow acquisition at the level of the annulus, not at the tips. But for other reasons, we want to get both tips and annulus in each case. Simple application of the hemodynamics is quantifying MR. So stroke volume when the ventricle contracts leads to flow through the aorta and flow back to the left atrium because of the MR. So if I know the stroke volume, the difference between end diastolic and systolic volumes, and I subtract from that the aortic flow, then I end up with MR volume. Very similar principle is sort of, or may be used in the cath lab in the older days when they used to get biplane ventriculography and LV volumes. They get the 2D stroke volume, they subtract from that the cardiac output or the stroke volume by the PA catheter, and assuming there are no other valve lesions, the difference is the regurgitant volume of one single leaky valve. We have the advantage by echo of being able to address multiple leaky valves. I can tell you the amount of leak if there is coexisting MR and AR. Example is shown here with a flail segment and bed MR. And these are the calculations. If you just take a quick look and look at the TVI across the mitral valve and you look at the TVI across the LVOT and you say to yourself, this is a big ventricle, this is a normal EF, how come I have a small velocity and a small TVI? That raises the flag without any calculations that there is significant MR. These are the values and you can combine them as we just said and quantify MR. The same can happen for aortic regurg. Here we are looking at flow through the LVOT and through the RV outflow tract. So we do this day to day in the echo lab for those who look at regurgitant valvular lesions. We'll move from flow to pressure. Energy is defined as capacity of doing work, and we can skip several of these points, but if you go through them one by one, it's not challenging really to get there. But the bottom line is the density multiplied by volume multiplied by free fall acceleration by the height is called the potential energy. Whereas the half mv squared that you are all familiar with, and here I don't have mass, I replace it by as the product of density and volume gives me kinetic energy. This is Bernoulli's law saying that the energy at one point is equal to the energy at another point. Flows also at point 1 is the same as flow at point 2. And so if I know the area velocity or time velocity integral at point 1, and I know the velocity or the time velocity integral at point 2, then I can calculate area. That's the principle of the continuity equation. When the blood goes into a narrower tube, the velocity goes up, and therefore the energy at point 2 is more kinetic, whereas the energy at point 1 is more potential. This is the full Bernoulli equation, and because these are at the same level compared to the center of gravity, you can drop the factors that relate to potential energy, and you can reduce this to pressure plus kinetic energy, point 1 equal pressure plus kinetic energy at point 2. You rearrange that expression because you are interested in calculating the pressure gradient. When you take a look at this, if V1 is very small compared to V2, its square is even smaller, so you can ignore that part, and it becomes the half dV squared. And this is for those working with units to see how we came up with 4V squared, but pressure is basically 4V squared. I'll skip the limitations. These are the applications, looking at PA pressures, gradients across stenotic valves, prosthetic valves, intracavitary gradients, calculating dP/dt for the left ventricle using MR jet, dP/dt for the right ventricle using the TR jet. Then you can look at estimates of LV/EDP using AR and estimates of LAP using MR. This is the TR estimation, PA 4V squared, and then you add the RAP. We can do the same for the pulmonary artery diastolic pressure. We use here the end diastolic velocity, 4V squared plus RAP. This is a gradient through aortic valve of about 4 meters per second, so 64 millimeters mercury. We get it from several windows. A patient with mitral stenosis and pretty significant stenosis, notice the peak velocity is more than 2, and at end diastole, still that velocity is pretty high, more than 2. You can quantify this and measure it online, offline, but that simple display gives you a complete story that there is severe MS. Doppler assessment of gradients are very accurate. These are recordings with pressure and Doppler from the same patient. The patient has atrial fibrillation and has a mechanical prosthesis, so there are varying RR intervals, which results in variable gradients, LA to LV gradients. Notice how nicely the Doppler gradient matches the mean gradient by cath. 10 for 10, 14, 14, you can go through this. And that has been shown by several investigators, though as you can imagine, these sort of studies are not common to do. LVOT dynamic gradient with 4V squared. This is the dP/dt concept. We do not use this routinely, but more for research purposes. There was a time when people were interested in acute effects of atrial synchronized bi-V pacing, and they used the dP/dt that route. You can do the same for TR. This is the AR jet for LV/EDP. You go for the end diastolic pressure. You subtract the 4V squared from the diastolic blood pressure, and now you have the EDP.
We kind of mixed things up a little bit these last couple of sessions. So what I'm going to do first is talk a little bit about the role of CMR for assessment of LV function. And then the role for CMR for hemodynamics, we're going to actually pick that up later in the year when we talk about valvular heart disease. So obviously, why use CMR? You know, one of the things we know is that accurate assessment of chamber sizes as well as global and regional function is very important clinically in a variety of different heart conditions. We know that echo is the most widely used modality because of its low cost, portability, as well as widespread availability. But there are occasionally limitations, suboptimal acoustic windows, there is some operator dependence, and then there's the need for geometric assumptions. And so some of the advantages of CMR, I think, as I'll try to show you, is that it offers fairly high spatial and temporal resolution, very good signal to noise, the ability to image the entire chest, and the ability to really have a free choice of imaging planes. And then lastly, does not need geometric assumptions. So let's go through and talk a little bit about how we would actually do a CMR study for assessment of LV function. So what I've got here is actually a series of short axis views that are obtained from the base of the heart all the way to the very tip of the heart. And notice I position this short axis view off of a series of long axis views so I can make sure that I'm truly perpendicular to the axis of the ventricle. And then in addition to that, these slices are acquired every 10 millimeters from each other. So these are all slices that are 1 centimeter from the next. So let's talk about how we first actually obtain the images. And so there's one concept that I think we need to understand, which is the idea of segmentation. So does anybody know what segmentation is? The answer is not there. So, okay. So it's the idea that I'm not going to obtain the entire image all at once, because MRI is fundamentally a slower modality. So instead, I'm going to actually obtain the image over multiple different cardiac cycles by acquiring a series of segments. And so a graphic display of that would be, during the first cardiac cycle, I acquire a few lines of data. I could actually, the other unique thing about MRI is when I acquire a few lines of data, it's not like I'm acquiring the top lines or the middle lines or the bottom line. That's shown here, but reality with MRI is that every line of data somehow contributes to the formation of the image. But if I have a small number of lines of data, then I have a low resolution image. But I can reconstruct the image with just the lines of data that I get from just one cardiac cycle. But I can then go to the next cardiac cycle, acquire some more lines of data, and notice now I'm able to reconstruct a higher resolution image. And if I keep doing that over and over again, I keep getting a higher and higher resolution image until I get the level of image quality that we want. Now the one unique thing here is I can dial this up or down. So I could say, so the example image I gave you here is about 1.5 millimeter pixel size, and that took about 4 to 6 heartbeats to acquire. But I could, if I said I want to make this 1 millimeter spatial resolution or 0.5 resolution, I could do that, but it would take me not 6 heartbeats, but maybe 8 or 10 or 12 heartbeats to do it. So I can change the resolution as I want, but the trade-off obviously is that the more resolution I want, the longer the breath hold or the acquisition time becomes. Okay, and this is actually just showing you that same, the heart reconstructed with a small number of lines of data. So if I only acquire 16 lines of data, I get a fairly low resolution image with big pixels. As I get higher and higher, or larger and larger number of lines of data to generate my image, then I get smaller pixel sizes, and therefore I get a higher resolution image. But you have the ability on the scanner to make these adjustments as you wish. Now obviously, what I showed you before was what you would do to generate a single still frame image. But when we do city images, what we really want to do is actually generate a series of images that are all at slightly different points in the cardiac cycle. So if this is my RR interval, these images are all at slightly different points in the cardiac cycle. And then when I play these one after another as a movie loop, I then am able to appreciate the phenomenon of motion. So it's no different than if you go to the movie theater. And again, obviously it's a function of what the temporal resolution of my acquisition is, right? So if I have a poor temporal resolution acquisition, it'll be like watching movies back in the old days. Whereas if I have a very high temporal resolution, that means that each frame represents a smaller and smaller interval in time, then I get a much more smoother appearance of motion. So as a frame of reference, typically with CMR, we try to achieve a temporal resolution of about 35 to 40 milliseconds per frame. Now, to give you an idea, what is a typical temporal resolution with echo? Does anybody know? And there's two ways you can think of temporal resolution. You can think of it as the milliseconds per frame, or you can think of it as the number of frames per second. And they're really just interrelated. So what is it for echo? 30-something? So echo is probably about 25 to 30 frames a second, right?
Actually, it depends. We have abilities to record much higher than 100 frames per second.
Right, if you reduce the depth.
We can also change the width. We can also, some systems would allow you to go up on the frame rate. So it is something within our control. And it depends on what is the question that is asked. How fast are the events happening that I want to resolve?
So for standard acquisition, it's probably about 30 frames.
30 or so.
30 frames a second. And then with CMR, we're typically dealing with about 20 to 25. But again, just as with echo, you can adjust this however you want. But again, everything comes at a trade-off. So if I want more frames per cardiac cycle, then it's going to acquire a longer acquisition time, therefore a longer breath hold.
Ability to recognize the presence of arrhythmias.
Well, I'm going to get to that next. So that's a very good question. So let's talk a little bit about how we do the acquisition, okay? So, as we talked about for a cine acquisition, I want to obtain multiple different frames. And we mentioned the fact that to get a high resolution image, MR cannot do that all within one cardiac cycle. So I'm going to actually do is take this first cardiac cycle and break it up into, let's say, 20 different phases or 20 different frames, so that the first 40 milliseconds of lines of data go to image 1, the second 40 milliseconds go to image 2, and on through the entire cardiac cycle. And then I now go to the next heartbeat, and I again acquire these lines of data, and again bin them appropriately, and I keep doing that. So now I'm actually able to obtain not just a single image, but actually a movie or a cine loop, which allows you to appreciate contractile function. So now, the issue is that since we're obtaining these images over multiple cycles, there can be sources of error that can occur. So let's get into what are the potential errors that can occur, because I think it's important for us to be able to recognize when we see an error what the potential cause of the error is. It's as important for physicians, it's also important for the technologist. So here's an example of an acquisition, and what does it look like is the problem with this acquisition. So what you always do is look at the image and say, okay, how do the details of the image look reasonable, or do the edges look blurry? And then next look at, am I able to appreciate the entire cardiac cycle, or is part of the cardiac cycle being cut off? Right, so you're actually missing the end diastole. Now we're not missing end systole, right, because we're actually seeing contractility. What happens is we've cut off most of diastole. So not just end diastole, we're probably missing most of diastole here. So the problem here is actually that on the scanner, when the tech was scanning this patient, and you tell the scanner this, to acquire data for the first 700 milliseconds, well, this person's heart rate was slower than that. So this person's R interval actually went out to 800 milliseconds, but if we stopped acquiring data here, then we missed the last couple of frames of the cardiac cycle. And so that's what's happened here, is that the acquisition window has been set incorrectly. So this is not a problem with the patient. This is not a patient arrhythmia or anything like that. It's simply an acquisition problem with the technologist. Now, what about this image here? So how does this look? So do you see systolic contraction nice and smooth? So yeah, the problem here is actually you've got one full cardiac cycle, but I've actually got a little bit more of the next cycle as well. Right? See that little blip at the end? So it's actually going into the next cardiac cycle. And so this, again, is an issue. If you're using a perspective acquisition technique, you tell the scanner, once you see an R wave, acquire, in this case, we purposefully set it to say the R interval is 1,000, but in fact, this person's R interval is only 800 milliseconds. So therefore, I've got a couple of extra frames that are acquired, but these are actually acquired in the next systole. So that obviously is suboptimal to be able to look at as well. So when you see that error, you say, okay, I need to reduce the acquisition window. And this can be either a function of I made a mistake in setting the acquisition window too long, or it could be that the patient's heart rate is sped up between when I set up the sequence to when I actually ran it. Now, what about this here? May not project as well. If it's a little bit dark, but what's happening here is, notice diastole actually looks nice and smooth, right? The contours, the endocardial definition is pretty good, but you notice during systole it's a little bit blurry, right? And the problem here is that the temporal resolution is suboptimal, all right? So instead of the 30 to 40 millisecond temporal resolution, this now was done with the 80 millisecond temporal resolution. So as a result, that systolic motion actually looks blurry, just the same way as if you're taking a picture of a moving object, unless you have a very fast camera. And then here's another example, and what's the problem here? So are you able to see nice systolic contraction, relaxation? Are we cutting off a part of the cardiac cycle? So there's nothing wrong with this acquisition. In fact, this was done with a very high temporal resolution. So this was actually a 10 millisecond per frame acquisition. So again, I can make those changes as I want to on the fly. Now the cost here, though, is that the breath hold time is much longer. So this was a 30-second breath hold. So this is one of our techs who's young and healthy who could do this, no problem. But the average patient is not going to be able to do that. So the ideal resolution is whatever is optimal for any given patient as far as how long they can hold their breath for. This is a case where the resolution is too poor. It's 80 milliseconds. This is a case where it's 10 milliseconds per frame. The ideal is somewhere in between. Okay, so now let's get to the issue that Dr. Nagueh was pointing out, which is to do this acquisition, it requires us to have good EKG gating and to have a normal heart rate. And also, because this is obtained over multiple cycles, it also requires adequate breath holding, because if the patient is breathing throughout the acquisition, that's going to corrupt the image as well. So let's talk about arrhythmias and then the strategies that we can employ to try to get around those problems. And so the first thing I look at when I think about arrhythmias is really classifying them into regularly irregular or irregularly irregular arrhythmias. Okay, so in other words, if somebody's having an arrhythmia but it falls in a very regular pattern, so for example bigeminy would be considered a regularly irregular arrhythmia, whereas for example atrial fib or random ventricular ectopy would be considered an irregularly irregular rhythm. And so here's an example. Here's an acquisition. This is a patient who has ventricular bigeminy. And you'll say, if you look at this image, it doesn't look so nice, does it? Right? And it looks, again, the contours look very blurry. Right? So what's a strategy you could employ here? Well, again, since this is a regularly irregular rhythm, you could actually fool the scanner. Instead of telling the scanner that this person's R interval is 800 milliseconds, you know that if I take the entire block of the normal QRS and the PVC beat, that entire block may be 12 or 1300 milliseconds. So I'll fool the scanner and I'll say, okay, this patient's heart rate is actually, R interval is 1300 milliseconds. And then I get an acquisition that looks like what I see on the right-hand side, where I've actually captured both the normal QRS as well as the PVC beat. So again, because it's regularly irregular, everything is happening the same each time. So I've just basically acquired 2 cardiac cycles instead of 1, but everything is the same between the first set of acquisition and the second set of beats and the third set of beats. So again, this won't cause a problem with the acquisition. Now what about if we have AFib, right? Or we have somebody who's got a lot of PVCs, and then obviously you can get poor image quality. So there's other strategies we can employ there. One of them is to use what's called an arrhythmia rejection technique. So basically, what I can look at it and I can say, look, this person, most of their R intervals are around 800 to 900 milliseconds, but they have some that are longer or some that are shorter. And so I can say, okay, let's discard any R intervals that fall outside of this window of 800 to 900. So it rejects certain beats and accepts only the beats that fall within the proper acceptance window range. And we set that on the scanner. So we set what the target is, and we set what the range of the window is. So typically you would say, let's say it's 850 milliseconds with an accept window of plus or minus 50 or plus or minus 100. Right? You don't want to have the acceptance window too wide, because if you're capturing beats that are way, way long or way short R intervals, that's going to corrupt the image. And then in this person with AFib, by employing that strategy, you'll notice we've actually got a very nice quality image here. Because again, I've discarded any of the really short or the really long R intervals, and I'm only acquiring the lines of data or the cardiac cycles that correspond to a certain time period. Now, one of the downsides with this, so this arrhythmia rejection sequence is great, but it does have some consequences. Because notice, if I said that for this level of resolution, for this temporal and spatial resolution, I need 6 heartbeats to generate my image, that means I need 6 good heartbeats to generate my image. Now, if I'm discarding beats, then I've got to replace those beats, so now the acquisition time gets longer and longer and longer. And so the problem is, if you have somebody who's having a lot of arrhythmias, the breath hold time can become way too long. This thing can just keep running forever. Because generally the way that this arrhythmia rejection is designed, the sequence is designed, is it discards the aberrant beat, either too short or too long, as well as the beat following that. So you're effectively discarding 2 cardiac cycles And if your arrhythmia or your irregular beats are happening quite frequently, then the breath hold time can just be way too long for the patient to be able to tolerate. And then, so in those cases, there are other little tricks that we can do, which is you can actually fool the scanner into saying, you know what, just give me a, do a perspective acquisition with a relatively short RR, so I just focus on systole. Because again, what I'm really interested in is systole, not so much diastole, if I'm just looking for contractile function and ejection fraction. So this is one strategy we sometimes employ. And so for those of you, when you rotate through the labs, you'll see we use a variety of these different strategies. And there's not that one strategy works every time. It really depends on each patient. And so you go through and based on the type of arrhythmia they're having, decide which particular strategy you're going to employ. Now, the other thing is obviously is a problem also is breathing, right? If the patient is breathing during the acquisition. Now, first thing is we need to be able to recognize when it's a problem in the acquisition because of breathing versus when it's a problem in the acquisition because of arrhythmia or gating. So I've got two examples here. One of these is a problem of breathing, where the patient's breathing through the acquisition, and the other is a problem of gating. So the patient's holding their breath just fine, but they're having arrhythmias or there's a problem with the gating so that we're not picking up the proper EKG signal. Looking at these images, can you tell? Because obviously, the way you're going to fix this problem is you need to know what the problem is to be able to fix, right? So can you tell by looking at the images which one? So raise your hand. Who thinks patient A has a problem with breathing? Raise your hand. Okay. Who thinks patient A has a problem with gating or arrhythmias? Okay. And then obviously the opposite for B. So most of you are right, and here's how you tell. So how is it that you were able to tell? Who said A? But remember, it's not so much that the organs are moving, because the organs could be moving on this here as well. It's that look. Well, no, so look at the abdominal structures, right? Are they nice and sharply demarcated? Right? So it's because remember it's not like the breathing is happening to synchronize with the cardiac cycle, right? So you're not going to see breathing motion that synchronizes with your cardiac cycle. What you're going to see is the image looks blurry, right? So in this case, the person's not holding their breath, and all these abdominal images look blurry, as well as the cardiac images look blurry. The other thing also is if you look at the image, what about even end diastole, the very first frame? Does it look normal or blurry? It looks blurry. Everything looks blurry, right? If you look on this side, abdominal organs look normal, right? And then the other thing is if you look at the very first frame, right? Actually, it actually doesn't look, the very first frame doesn't look blurry, because again, the very onset of the R interval is essentially the heart's in the same position each time. So identifying what the problem is will allow you then to go on and fix the problem. All right. Now, as a last resort, let's say we try all our tricks and we can't do it, either because the patient can't hold their breath or because they're having arrhythmias. Well, we can go to this thing called real-time imaging. So I said MRI is a slower technique, but there are tricks that we can do to actually obtain the entire image in real time, but it comes at the cost of slightly lower spatial and temporal resolution. And so here's an example. So on the right-hand side is a regular high-res acquisition that took about an 8-second breath hold to acquire. On the left-hand side, this is a real-time acquisition here. So this requires no breathing, no gating, nothing. So because these images are taken in real time, I've compromised a little bit. So instead of 1.5 millimeter pixels, these are about 3 millimeter pixel sizes. And instead of about 30 to 40 milliseconds temporal resolution, this is about 50 milliseconds, 40 to 50 millisecond temporal resolution. And then we've done other things like parallel imaging and things like that, which cause a reduction in the SNR, which allow you to do the acquisition faster. So what I always tell our techs is, no matter what, we should never have an image worse than this, because you can always do real-time image on every single patient. All right. So this is the worst quality image you should ever see on a CMR scan.
Is there a heart rate limit for that?
Well, so obviously the issue becomes if you have a 40 or 50 millisecond temporal resolution, but if the patient's got a heart rate of 150, that 40 or 50 millisecond temporal resolution may not be sufficient, right? So yes, if you've got somebody who's very tachycardic, but in normal heart rates of between 60 to 100, that 40 to 50 millisecond temporal resolution is reasonably good. And then you can always change that, because there's other tricks I can do where I can go to higher levels of acceleration to improve my temporal resolution at the expense of slightly worse signal to noise. So there's different things that you can do for each given scenario. So let's kind of move on to how do we, so we talked about the basics of how we actually generate a cine image. How do we then go through and determine volumes and ejection fractions? So again, as I touched on earlier, with CMR, there's no geometric assumptions that are being made. Instead, since I've acquired a series of short axis slices from the base to the apex, what I would do then is go through and contour each of these individual slices, summate the volume of each of these slices in diastole, and do the same thing in systole as well. And then I get the end diastolic volume and the end systolic volume, and then you can use that to compute what the ejection fraction is. And obviously there's a wealth of validation data that goes back into the 80s and 90s in a variety of settings, both in humans as well as animals, as well as actually in this example here, where they looked at casts of cadaveric hearts, showing that you get fairly reliable measures of volumes as well as ejection fraction by CMR. And again, without the need for geometric assumptions. Let me skip past this here. There's a couple of things that are important, I think, to be able to identify, which is because we're acquiring a tomographic acquisition, and the patient, when they're in the scanner, there's a coordinate system, you can actually see exactly where this short axis slice is in relation to other long axis slices. Because it's a coordinate system, you can see that this short axis slice here is situated here in relation to a 4-chamber view. This is important because when the acquisition was done, it was done off axis, right? If I have an off axis short axis view, then that could cause error in my volume as well as wall thickness calculations. So I can actually look at this. I can also see to make sure that I've got slices that are going all the way from the mitral annulus all the way down to the very tip of the heart, right? Because I've got a series of slices. I want to make sure that the tech didn't leave off 1 or 2 slices at the base or leave off 1 or 2 slices at the apex. So in addition to being able to tell that by the image itself, the way the image looks, I can actually see exactly where each individual slice sits in relation to a long axis orientation. And then, so this is the idea of doing what we call long axis cross-referencing. So I look at my series of short axis and I see where they sit in relation to a long axis view. And then, in addition to that, that's useful because I want to make sure that I incorporate the basal slice, right? I want to make sure that I'm encompassing the entire volume of the ventricle. Because notice at the very basal slice, there's a large amount of volume that's present here. And so if you lose one basal slice, you could lose 30 or 40 cc's of blood volume, and that could give you a significant error in your measurements. So that's why it's important to be able to do this. Also, it's important to be able to recognize that the base changes. The location of the base changes. Now, when I specify a position on the scanner, it's picking an exact specific anatomic location. If the heart itself is moving, in this case, you'll notice the base of the heart between diastole and systole is actually descending down. I need to make sure I account for that when I do my volume calculations for systole. And so by looking at these cross-referenced long axis views, I can see that this slice right here in diastole is within the ventricle. But notice that same position during systole, when the heart has descended down, is no longer now part of the left ventricle. So when I trace this, I would trace this volume for diastole, but not trace this volume for systole. And this is crucial not only for getting an accurate EF, but more importantly actually for deriving an accurate stroke volume. All right, because what I see commonly done at other labs is people will trace both slices within this given short axis slice, both the diastolic and systolic, without accounting for the fact that there's base to apex descent. And as a result, you get a significant underestimation in stroke volume, right? Now that can affect your EF calculation, but more importantly, as we'll talk about later, when we do things like mitral regurg or AI assessment, that's when it can have a problem with those quantification as well. The other important thing is this is not a fixed value. This base to apex descent varies from patient to patient. So you have to actually look at each individual patient, look at the frame that you've got as your basal slice, and see what happens for that person during systole. In some people, there's no base to apex descent. In some people, you may actually have 2 slices, 20 millimeters of base to apex descent, in which case you may have 2 slices that you don't trace in systole, but that you do trace in diastole. So you have to really look at the images to determine what's the ideal way to do the tracing. Let me skip past the issue of the papillary muscles. We'll skip past this here. And then just talk briefly about the numerical values that we get by CMR. So we have actually numerous studies that have derived normal values by CMR for end diastolic and systolic volume, as well as ejection fraction and mass. And so it's important to make sure we look at the normal values that are done with the CMR technique that we're using, and recognize that it can be quite a bit different than normal values, for example, by echocardiography, where normal end diastolic volume index by echo in this publication was in the guidelines was 35 to 75, whereas you can see for men, the normal end diastolic volume index, which is shown here, is anywhere from 57 to 105, and for women, 56 to 96. So you need to know, before you start calling dilatation, what are normal values for the imaging modality that you're using. And the same thing for CT, they'll have a series of normal values as well. The other thing also is ejection fraction. You need to know what the range of normal values are. And this is one area where I think it's a little bit different than echo. The lower limit to normal for ejection fraction by CMR is really on the order of between 57 to 60%. All right, that's a lower limit to normal. So you may have somebody who has an EF of 53, and we would call that mild LV dysfunction. So don't be surprised. And I think it has to do with the fact that there's a fairly tight range of normal values by CMR. Now the other thing it's also important to keep in mind is that normal values change with aging, right? So this actually is a series of patients that they looked at in different deciles of age, 20-year-olds, 30-year-olds, 40, 50, all the way up to 80-year-olds. And you can see when we talk about end diastolic volume, there's a gradual decrease in both the mean as well as the upper and lower bounds of end diastolic volume with aging. And then the same or the opposite thing for ejection fraction, where there's a gradual increase in ejection fraction with aging, both the upper and the lower bounds. And so I think where this is important is if you have a young person who comes in and there's a question of does this person have LV dysfunction, it may be just that the ventricle looks big and it looks a little sluggish, but that could just be normal for a very young person. So again, we always want to make sure that we look at these values that we get and really index it both to body surface area as well as gender, because there's differences between males and females, as well as decile of age. Okay, let me skip past this here in the interest of time. And then again, this is just one of several publications which have shown that values that you derive in the same set of patients may be different between CMR versus echocardiography. And again, this was a cohort of patients, some with normal function, some with mild LV dysfunction, and some with severe LV dysfunction. And what they found, in fact, was that the CMR ejection fractions tend to be different than the ejection fractions that you get with unenhanced echo. And then obviously with the administration of contrast, the echoes, or there's a greater concordance between the two values, both for EF as well as if you look at for end diastolic volumes also for this group of, and again, these are not normals, these are series of patients. For this same cohort, you had an end diastolic volume of 174 by CMR, whereas by echo, it was 115. So there can be actually a pretty significant difference between echo and MR. And then this is one particular study which showed that with 3D echo, for example, you tend to get a little closer relationship. But again, it probably has to do with the fact that it's the lateral resolution that you can very nicely delineate with CMR. So you can actually identify that there's all these trabeculations, but we will trace into the cavity all the way to the edge of the wall. And in this particular study, what they demonstrated was that there's actually a better correlation between 3D echo and CMR if the CMR were undertraced, in the sense suggesting that with 3D echo, all these trabeculations, you're not able to necessarily resolve those. And as a result, that may explain why you get lower values, lower volumes by echo than you do with CMR. So again, to kind of summarize, what's the clinical role of CMR for LV function assessment? Obviously, if you've got a situation where you need to quantify LV function and you have discordant information between prior tests, if you have a patient who has had a prior MI or heart failure and who has technically limited echocardiographic images, and then for patients with congenital heart disease, we didn't get a chance to get into this, but especially for the RV, CMR has optimal ability to quantitate both RV volumes as well as RV ejection fraction.